And so I'm going to turn the meeting over to Susan. Thank you.
Thanks so much, Catherine. I really appreciate it. This is great. I'm so happy to be here. And I will just preface my remarks by saying that Amanda and I decided that we would collaborate this evening as we have other times. And so I'm going to sort of be setting up the context, and Amanda's going to follow up with some actions, and we'll just see how this goes. But to talk about long-term care at this particular moment in Canada, we could do well to anchor our discussion in three important recent events. Obviously, first, COVID-19 has revealed dramatically our neglect of already precarious long-term care systems, killing so many of our most frail older persons and infecting and killing some of those who provide their care. Second, the police killings of George Floyd and Rayshard Brooks have led to a huge resurgence of Black Lives Matters across North America and Europe. In Canada, this is bringing important attention to police involvements in the deaths of Indigenous women like Chantel Moore and Regis Korchinski-Paquette, the videoed police beating of Chief Alan Adams at a recent protest in Alberta, and reminded us of the police killings of Abdirahman Abdi and many others. These protests should have us newly considering common Canadian platitudes about reconciliation and multiculturalism. Now consider that across Canada, a large and growing percentage of long-term care workers are mostly women from racialized and immigrant communities. Racism against Black and Indigenous peoples and anti-immigrant bias deeply affect long-term care, rendering workers who are often and wrongly considered as low-skilled somehow responsible for the poor conditions in long-term care. Sexism, racism, and classist attitudes are a toxic mix, and they affect these workers' lives daily. Third, we have witnessed that despite decades of research, advocacy, activism, and many damning inquiries into Ontario's and other provinces' long-term care systems, it was only when the military, yes, the military, registered their shock and concern about abysmal concerns in long-term care homes that the Premier was finally moved to tears. These three moments lead to a rational yet horrifying analysis. In our society, we systematically treat some lives as disposable. How many times have you heard someone say, well, you know, she has dementia and can't remember her own family. She'd be better off dead. I've certainly heard it over and over again. Think hard. This failure to understand frailty and dementia renders older people disposable. On top of that, racism, sexism, and classism render workers' lives disposable. Bringing the military into long-term care emphasizes both some political desperation, in my view, to show action in dealing with an embarrassing and unmanageable situation and the result of years of depletion and neglect. Why aren't there adequate policies and procedures for communicable disease outbreaks in long-term care homes? This is hardly the first time. We have annual flus, we've had Legionnaire's disease, and many others that have happened. The reality is the long-term care system, the residents, the workers, have all been treated as disposable. A recent Ontario Premier, considered progressive, said not long ago to one of my research colleagues in a private conversation that was reported to me that long-term residential care was a money pit, as if no amount of government spending or action would be enough to fix it. Yet Ontario has never, ever approached a level of spending as a percentage of GDP similar to many advanced welfare states with much more robust systems existing around the world. As Mary Catherine mentioned earlier, two for-profit companies are responsible for almost 1/3 of the deaths in long-term residential care homes, Sienna and Rivera. 6 companies account for at least 1,000 of the 1,792 nursing home resident deaths in Ontario. But we know far less about workers' infection rates, and it is safe to say that workers who are employed in for-profit care homes are likely to be more affected. And of course, these workers bring this highly infectious virus home to their families and their communities, as we've seen in Montreal. So How did we land in this mess? Well, let's do a little history. Long-term care has changed a lot over the past several decades, and it continues to change quite rapidly. Years of healthcare reform going back decades have transformed the nature of long-term residential care in Ontario. Once mostly a public system, now 57% of all nursing homes are owned by for-profit providers. Legislated staffing requirements were removed, and then even what staff were there were downgraded. And instead of an education-focused inspection regime that we once had, we now have a penalizing and often just plain not there inspection regime. Quality measures were introduced that measure the absence of problematic and dangerous conditions rather than the presence of good ones. Chronic care and psychiatric hospitals have closed. Acute care became more narrowly defined, and hospital stays have been significantly shortened. Home care now accommodates some of the people previously treated in these healthcare facilities, but those with complex care needs or whose care requires special equipment are now in long-term care. Ontario also has, like many other jurisdictions, an aging population, and although most older people are in reasonable or good health, a significant proportion live with multiple severe chronic conditions. Ontario has not invested sufficiently, and the number of beds in long-term care have not kept up with need. One indicator is wait times for admission. Once a person qualifies as needing 24-hour nursing home care, the median wait time in Ontario, the median wait time is 150 days. Further, the nursing home population has changed dramatically. 90% now have some cognitive impairment, and more than half of the residents are experiencing moderate to advanced dementias. 86% need extensive help with activities such as eating or going to the washroom. 40% need monitoring for an acute, not chronic, an acute medical condition. 61% take 10 or more prescription medications. Further, compared to the past, a growing number of residents are under 65, and more of these residents are male, even though it is still the case that most residents are women and that the average age is 83. Men tend to be heavier and more prone to violence. Further, heavier residents also mean that it takes two people working closely together to shift them, to get them in and out of bed, toilet, or dressed, and I've seen some take 3 people. Further, the labor force in nursing homes has changed. There has been a long-standing international and national long-term care labor shortage addressed through immigration policies and retraining program that really have had little success. Interestingly, wage rates have not risen significantly in this sector, partly because they're suppressed by governments who are not anxious to increase their healthcare budget in a sector where labor is one of the most significant costs. Different divisions of labor have been introduced. Part-time and casual work have increased in order to avoid employer benefit costs and to increase just the numbers to move around so that you have workers always looking, the workers that you have are always looking for more hours. Of course, this has meant that many workers have been forced to work at more than one home in order to earn even a modest living wage, a situation that became obvious during COVID when government moved to prevent workers from working at more than one home to prevent disease transmission. Workers took up positions with better working conditions, leaving homes with poor conditions severely understaffed. And these were the homes where the military landed. For the past 10 years, along with 3 teams of amazing researchers from across Canada and 7 other countries, I've spent about a month or more of each year doing observations in nursing homes in Ontario, across Canada, and other countries. Our research has focused on identifying promising practices, comparing across jurisdictions, seeking policies and practices that offer conditions of dignity and respect for residents and for workers. I've talked about these practices many times with this audience, and I'll provide a link in the chat to where you can read all about them on the Canadian Centre for Policy Alternatives website. We know what can work. Those of us with privilege and fury, like me, have a responsibility to use the current public interest now to advocate no more disposable lives. We need to take action now, and Amanda is going to tell us how.
Thank you, Susan. I'd like to thank the executive of the Ottawa Health Coalition for inviting me to join you for this evening's panel discussion. And actually, I will also thank Susan because Susan always makes herself fully available to me when I pepper her with my millions of long-term care related questions all of the time. So thank you to Susan as well. So long-term care is an issue I cover as a researcher with CUPE, but as was mentioned, I also worked in the sector for 7 years. I know how wonderfully rewarding working in long-term care can be, but I have also witnessed many of the challenges the sector faces. It's something I'm personally connected to and care deeply about. As Susan discussed, the situation we've witnessed over the past 3 months in long-term care is horrifying and tragic. While following the news about long-term care homes throughout the pandemic, I've oscillated between anguish, rage, and despair. Anguish over the appallingly high number of resident deaths and the deaths of long-term care workers who are both regarded as unimportant and disposable, as Susan argued. Rage over the slow response of homes and provinces to enact needed measures to protect the health and safety of residents and workers. Rage knowing that the systemic changes we need that would have dramatically reduced the high death toll and infection rates we're witnessing have been willfully ignored by successive governments at all levels. Although the systemic issues plaguing long-term care are receiving unprecedented levels of media coverage, and although politicians are describing the situation in long-term care as unacceptable, I despair that the moment before us to achieve meaningful change will pass as we start to recover from COVID-19 and establish a new normal. Will the Canadian public and our politicians forget or ignore the issues, fearing the cost of doing something, anything, is simply unaffordable? What helps me stay energized and focused on continuing to fight for the changes we need are opportunities like this, where I get to talk about the interdependence between the conditions of work and the conditions of care and the solutions to the problems the sector faces. This gives me hope because it keeps long-term care in the spotlight and might motivate interested folks like you to act for change. As Susan pointed out, we've long known what the province and long-term care are. The COVID-19 pandemic has showed us that the need to implement major changes within the system are long overdue and needed now more than ever to ensure a tragedy of this magnitude is not repeated. So what can and should be done to fix the problems in long-term care? In May, Ontario announced it will strike a supposedly independent, nonpartisan, and transparent commission and hold public hearings to examine the province's long-term care sector. And just yesterday, Quebec's chief coroner ordered a public inquiry into the deaths that have occurred in the province's long-term care homes and other seniors' residences. While I can understand the desire for a commission or inquiry, I don't think they are the right or key action that needs to take place at this point in time. Just under a year ago, the Ontario government released the report and recommendations of the public inquiry into the safety and security of residents in the long-term care homes system. The inquiry was established following Elizabeth Wetlaufer's conviction of 8 counts of first-degree murder, 4 counts of attempted murder, and 2 counts of aggravated assault against residents of long-term care homes where she worked as a registered nurse. The inquiry found that Wetlaufer was in part able to commit her crimes because of low staffing levels in the homes where she worked, particularly during the night shift, where she was able to act undetected. I'm still waiting to hear what changes the province has implemented to address the recommendations in the report, and I pessimistically suspect that they will sit and collect dust, much like the reports and recommendations of so many other provincial and national inquiries and commissions. Given that we already have decades of evidence-based research that tells us what we need to do in order to fix the problems plaguing long-term care, holding commissions or inquiries would waste both time and money. Current and future generations of long-term care residents, staff, and families can't wait years for recommendations to be released that may not even end up being implemented by governments of the day. We need changes now, and we know what must be done. So what are the key changes we need to see in order to address the problems Susan identified, and what can you do to lobby for change? We must demand that long-term care be part of our public health care system and that it be regulated under the Canada Health Act. This would make long-term care a publicly insured core healthcare service like doctor's visits and hospital stays. For too long, provinces and territories haven't kept up with growing needs in long-term care. Provinces and territories need more support and resources so they can all provide the same quality of care, but they can't achieve the standards we need to put in place on their own. The federal government must provide needed support. We must therefore demand that the federal government provide dedicated and adequate funding to the provinces and territories for long-term care through the Canada Health Transfer. No one expects that quality care for our parents and grandparents, and possibly one day for ourselves, will be cheap. But we have to acknowledge that the system we have isn't acceptable for residents or workers. The costs of inaction are far higher than the cost of improving the system. We must demand that the federal government implement and enforce evidence-based national standards of care, including staffing levels, and tie the standards to funding. The research shows that residents require a minimum of 4.1 to 4.9 hours of directly worked hands-on care per day in order to maintain their health status. Higher levels of care are required to meet the needs of residents with more complex needs. We must demand the elimination of the for-profit ownership and operation of long-term care homes. Private corporations and shareholders should not profit from people's medical needs, and governments should not put our health up for sale. Our tax dollars should be invested in resident care, not stakeholder dividends. We must demand a ban on the contracting out of essential services to for-profit companies, such as food, housekeeping, and laundry services. All services should be provided by in-house staff. When services are provided in-house, working conditions, infection rates, and resident quality of life all improve. We must demand that workers' wages be increased and standardized to reflect the complexity, value, and skill level of the labor they perform, particularly among care aides, or personal support workers as they're called in Ontario. We must also stand up for workers and demand they be provided with good benefits and adequate paid sick days. Workers who earn low wages and lack paid sick days are likely to come into work because they can't afford to take a day off and are afraid of losing their job if they call in sick. This puts everyone around them at risk. Workers must be treated fairly in order to eliminate that risk. We must also demand an end to the precarious nature of work in long-term care through the creation of full-time, regular jobs for workers who want them. In conjunction with paying workers a decent wage, this will reduce the need for staff to work at multiple homes, thereby reducing the risk that staff will spread infection between homes. This will also provide workers with greater job security, increase workers' job satisfaction, attract more workers to the sector, and enhance the continuity and quality of relational care between residents and staff. By 2035, it's expected that Canada will need an additional 199,000 long-term care beds. Ontario alone currently has almost 35,000 people on its wait lists. Hospitals have long operated well over capacity because there aren't enough beds in long-term care for individuals who need them. This situation became more alarming when hospitals had to rush to find ways to handle the expected influx of COVID-19 patients. We must therefore demand that more long-term care homes be built to alleviate capacity problems in hospitals and to ensure individuals receive the appropriate care they need when and where they need it. Public funds should be available to build new homes, and the facilities must not be designed or operated as P3s. Other areas where we can make demands include pension divestment of for-profit long-term care home ownership, improvements to inspection systems so they're regular, consistent, and supportive rather than punitive, changes to the way new homes are designed, and providing needed financial support to older homes that must be retrofitted, and holding homes and governments accountable by requiring the public reporting of staffing levels. Finally, if Ontario is indeed going to forge ahead with the commission it's proposed, we must absolutely demand that no individuals with ties to the for-profit industry serve as advisors to the commission. This is crucial given that we know there are deep ties between the for-profit sector and the Ford government. CUPE has launched a national long-term care campaign. You can visit our website at cupe.ca to learn more and to get involved in our campaign by sending a letter to Prime Minister Trudeau asking him to fix long-term care now. You can also write your MP and MPP or schedule a virtual meeting with them to discuss your concerns and lobby their support for recommended changes. There are also several online petitions that you can sign that are sponsored by the Canadian Health Coalition, the Council of Canadians, a group of family members, as well as a government petition sponsored by Federal Green Party member Paul Manley. You can also ally with other advocates who are concerned about long-term care, including the Family Councils of Eastern Ontario, the Council on Aging of Ottawa, and many other groups locally and provincially. The movement to achieve needed changes in the long-term care sector is now. We have a minority government, and we've seen many instances over the past few months where the Liberals have strengthened policy responses to the pandemic because of the need to win the support of other parties in order to pass legislation. This situation is advantageous to us. The time is right to exercise pressure and demand change. Thank you so much, and I look forward to our discussion and answering your questions.
Thank you, Amanda and Susan. Really good presentations. I learned a lot. People may be developing questions in their minds now as Amanda has finished, because we don't have a lot in the chat room, but I do want to bring up one that was presented by Kevin Scarrett, who's a regular with the Ottawa Health Coalition. He has heard and read about something that I was tweaking my interest as well. So let me read this to you. The Ford government may be on the verge of granting legal immunity from liability in relation to the pandemic and maybe beyond. This would be a huge de facto bailout to these companies after their reckless and lethal risk-taking. If there's a bailout such as this, if there's any bailout, should it not be a part of a public takeover of the sector? So I'm going to direct that first to Susan and see what your response is to that, Susan.
Well, my response to Kevin is that is exactly right. Yeah. I can indicate that this is just more of an indication of the close relationship that the Ford government and even the Ministry of Health and Long-Term Care has with the for-profit sector, with the owners, with even who are advising that government on their policies right now. If you take a look at the names and you see where they're located, you will understand these connections. So this is the advice this government is seeking, and it is the advice this government is taking. And I think, everybody here, it just feels like half an hour ago when we watched Goldman Sachs and everybody else get bailed out from the financial crisis, while all the people that were suffering got left holding the bag. We could potentially see this again. It would not surprise me, and fighting that would be very important. It is, after World War II, many private corporations were taken over by the public sector. Most You know, the example that I know best is in the UK, in England, where many services were made public for all kinds of reasons around rebuilding after the war. It happened in Canada too, and we've had a very strong tradition of crown corporations and public services of various kinds. There is lots of precedent for taking over a sector, absolutely. And this may be exactly the moment that we need. Not bailing out, but taking over.
Amanda, do you have anything to add to that?
I mean, I also completely agree with Kevin and Susan. I'd heard yesterday on the CBC that this information was being leaked, and I was completely horrified at that news. And you know, my concern is that governments will take the easy route of just throwing a pile of money at homes for homes to spend in any way that they choose, and not tie any conditions or standard to that money, so that they can then turn around and just say, oh, well, look, we threw a lot of money at the sector to make improvements, and we've done something, and leave it at that. And that won't help us to bring around the actual substantive types of changes that we need to see. So the concern is completely valid.
Can I just follow that up? Amanda, you were mentioning about the federal role here, and this is the time to kind of start pushing for that. So would we be calling for the federal government to be sort of the main emphasis on taking these homes over? I mean, we're going to get caught in this constitutional quagmire that we often do about whose responsibility it is. But the easiest way to do that, I'm starting to understand, is through the Canada Health Act, that it would be a fairly streamlined process to include the long-term care homes. What do each of you think about that process? What are we asking?
So there's all sorts of questions within that even single question there, Catherine.
Yeah, sorry.
No, it's okay. It's an excellent question. So the first answer I will give is, you know, how do we go about achieving our end goal of creating a public system of long-term care legislatively? So there is debate among activists, progressive activists on the left, and organizations about how we should go about achieving that. And the debate centers around, you know, should long-term care be regulated under the Canada Health Act, or should we create a system of public long-term care through separate legislation? Lots of folks are concerned with opening up the Canada Health Act and losing lots of the good things that we currently have in there, particularly the measures against extra billing and user fees. But for me, and I noticed that this was made in one of the comments, you know, I was initially one of those individuals who was greatly concerned with the idea of opening up the Canada Health Act, particularly that it would pave the way for profiteers to make sweeping changes to the act that we definitely do not want to see and have happen. However, long-term care is bricks and mortar and hands-on care, much like hospital care is. So to me, it makes sense if we think about continuity of care. You know, you have individuals who receive care in a hospital and then, you know, need to move into a long-term care home when they're no longer able to live independently in their home. And it's essentially the same style of care. It's just sort of delivered in a little bit of a different way. So that to me is what helps me make sense and feel more comfortable with the idea of incorporating long-term care under the Canada Health Act, because it shows that long-term care is as significant a priority when it comes to the delivery of healthcare as visits to physicians and visits to hospitals. And even if we created a public system of long-term care through separate legislation, there's still no guarantee that we would get all the goodies that we want in legislation included in a new and separate act. And in fact, I think the process might take longer to develop a new piece of legislation rather than just opening up the act a little bit to bring in long-term care. So there is much debate around that issue. And I wonder, Susan, do you want to comment about that too? Just about that part?
I mean, Amanda, you and I have talked about this as this debate has unfolded, both having those concerns and then watching the CLC kind of develop a position, watching lots of other people make persuasive arguments. So I don't think there's any strategy here that's without risk. And this has been a process of weighing risks and, you know, inserting long-term residential care in the Canada Health Act seems to provide significant benefits. It also, there are risks there to opening that up. So it would be important around strategy about sliding this in as opposed to opening it up and re-examining it. And would the provinces go for that? Looking at who are the premiers right now and how that would proceed. And so right now that, you know, I think it's important to maintain a common strategy. We know that when progressive people start arguing amongst themselves, it's a chance to divide us. Yeah. So my position has been, okay, this is what we're trying. We know the risks involved, but there are risks to any other strategy as well. And this one probably for the long term looks to be very promising. That being said, the standards have to improve. Yes. And I, you know, I feel like what I do in my life is now, you know, it's been set for a while, but this is just a battle that we just have to keep fighting and getting louder and more clear about. It's just so important.
Yeah, and Catherine, I was just going to say the other component of the question you were posing is sort of, you know, this jurisdictional battle over healthcare. And so, you know, even premiers themselves argue that healthcare is provincial jurisdiction, hands off everybody else. But of course, we know this isn't true. We have the Canada Health Act. We have the Canada Health Transfer. You know, we used to have a National Health Accord. We should have another one again. And so this idea that it's solely provincial jurisdiction is really a bit of a myth. That for those of us who are advocates around healthcare, we need to do a lot of work around that. And for me, you know, the provinces have shown that they can't offer the quality of care and the working conditions that are needed to promote quality of care on their own, either because of an unwillingness to do so, a lack of interest. You know, they'll claim there's not enough money. And so for me, we need to elevate long-term care up another level to the federal level and get the federal government involved, because if we don't, we will continue to have the iniquitous patchwork system that's currently in place across the provinces. So, you know, for example, some provinces have no legislated hours of care. Some provinces like British Columbia have a guideline, so it's just a target that homes should work towards but aren't required to implement. And other provinces do have legislated hours of care, but they all fall far below the minimum of 4.1 to 4.9 hours of care. So where you live in Canada determines, you know, the amount and type of care you receive and how much you pay for it. And until we have national standards, we will never reach, you know, equitable situation where, you know, it doesn't matter where you live in Canada, you can be assured that if you need to move into a long-term care home, you are going to receive the same quality of care, the same type of care anywhere in the country, And workers in the system can also be assured that they will be provided with equitable working conditions. That's also essential because recruitment and retention is a problem in every single province in the country.
Thanks, Amanda. I'm going to take the liberty of just changing our discussion a little bit. There are two things I wanted to make sure we deal with. One is I want to ask Susan about some of the policies and practices that you have seen and have been taken by that we could be implementing here. There's also, I think, an interest in pursuing what have the effects been of the pandemic in long-term care vis-a-vis home care. And with the province moving ahead to change home care dramatically, what are the prospects there? So I'm going to go back to examples. Perhaps the person that had the question was looking at intergenerational environments for long-term care. Susan, do you have any thoughts you want to share?
Yeah, I mean, internationally, we have seen many different models or approaches to nursing home care, including ones where a nursing home is, for example, one of the ones in Norway that we really were taken by was one that was actually attached to a shopping mall that also had the area swimming pool and tennis courts and everything else, all attached in the same complex. So we were watching families interact. Older people would be coming with them to do their shopping, to watch the kids have a swimming lesson, to going outside into the area with the tennis courts and everything else. And this was all in one facility. You can imagine there was a daycare there as well, so that workers' kids were in that daycare. This was in the hub of a community where there was a lot of action, a lot of ability to drop in and to include and to feel a part of things, a part of the heartbeat of the community, so that this home was really part of a whole place of gathering for the whole community. And even if your family weren't around, you could be out and mixing and meeting without too much trouble. And people were, and people took advantage of it. And it wasn't intergenerational living in the way that was presented in the question, but it was intergenerational life, and it was intergenerational liveliness. And it was about being a part of what was going on to the extent that you wanted and having that easily available, which was really impressive and gave a lot of what I can only call joy to people, including people that were living with significant dementia, but who enjoyed this sense of being about and around familiar places and things and enjoying life. So that was one of the best examples in the stories. I just tried to take you there for a minute because it was just so lovely. We've seen many variations on this kind of experiment, including even where long-term care homes are located. So for example, in Sweden, we saw a number of long-term care homes that were actually located in urban areas just above shopping streets. So, the shops would be on the lower level, and then the long-term care home would be above, so that when the long-term care residents looked out their window, they were looking out to a shopping street and seeing all that. And with elevators, their families were easily able to take them into the community. Most of the people that lived in that home were from that neighborhood. And there was a sense of, again, still being able to connect with, not being removed and shut away and sent off to green pastures, something that most urban people really don't want, but being still a part and being a part of the city and a part of the life of the city and having that available to them, even if it's only out the window, but also if they're able to be able to be out and about. So you can also imagine that in that kind of environment, things like weather are, because Sweden has weather, are still easier to deal with and less confining if you're out to an urban street. So we've seen lots of models like that, and there's no reason why we couldn't do that in Canada. In Canada, we have tended to go to a green acres kind of model for long-term care, even when they are urban. We stick them off into sort of a suburban area, put a green space around them, and assume that that's the best. The evidence is actually very uneven about that. It's not that green space isn't lovely. It isn't nice that it's lovely to have gardens and areas that you can access outside that are safe. But this idea of kind of, putting it off into its own campus and leaving it there is actually, there's significant evidence that says this isn't the best idea for long-term care. So there's ways that we can incorporate it. In order to run long-term care now, you need to have over 100 beds. It's just economically not feasible under the current regime to have smaller places. You need that volume. We've, in our project, there's a bunch of us who like to crack numbers. We've taken a look at it. I've brought them home. I've brought home anonymized numbers so I could have my chartered accountant partner go through them and take a look and make sure that we were adding correctly. And I think we've come out to the same conclusion every time. You need a certain volume. So how do you do that? How do you adjust for that, given the hopes for intergenerational life? And so that's where we've been looking for practices that aren't saying, oh, we need places that are smaller and that have lots of different housing for different ages. More, we're saying, if you need that volume to make it under this regime, it would cost so much more and not increase staffing one bit to make them smaller. So let's keep them big. Let's increase the staffing if we're going to spend money, and let's figure out how to make them intergenerational in other ways. And that's kind of the thinking that we've been working with over the last few years.
Thank you. That's very interesting. Amanda, do you have anything to, I was thinking as Susan was speaking that you had worked in 2 homes over 7 years. You must have some ideas from a staff point of view, what you...
Uh-oh, Catherine just froze. She's frozen. So what I think Catherine was going to ask me was, based on my previous work history in long-term care, maybe what are some of the lessons learned about creating an environment that enhances quality of care. So the first home, so both of the homes I worked in were nonprofits. So both were private, but not for profit. The first home I worked in was small, and it absolutely set the bar as high as we could possibly go in terms of creating, top quality living environment for folks who live in long-term care. In addition to, one side of the building was long-term care. On the other side of the building was private apartments. So what was interesting, being not-for-profit, was that we were able to transfer some of the profits made from the apartments over to the long-term care home, because of course, as we all know, long-term care is highly underfunded. And so that was one of the ways in which our CEO was able to enhance quality of care in the home, both through staffing measures, but also the amenities at the home. So the job I had at that home, I actually ran a fitness center that was fully equipped with exercise equipment designed specifically for use by seniors and individuals with severe mobility problems. We were also open to community members, but they had to be at least aged 70 in order to join. We also were home to an adult day program. We had a cafe. We had a fine dining restaurant that we would run twice monthly, so residents could have their family members come and join them for a fine dining meal. We had a movie theater. We had a woodworking shop. We had an on-site hair salon. We had a gift shop. We had our own accessible bus and our own minivan, so we could take residents out of the home on regular outings or to buy their own groceries if they wanted to. And honestly, I used to joke with my coworkers who were my friends. You know, I worked there when I was in my early 20s, and we joked even then that because the waiting list was so long at the home, we wanted to put our name on the list now, because if we were ever going to end up in long-term care, that was where we wanted to go. The second home I worked at, I had returned to school, and I had a part-time job at another home, which, as I mentioned, was also private, nonprofit, and the difference was night and day. It was a massive building. It was a new building, so it looked clean and pretty, but the feel in the home for me was very institutionalized. It felt more like, I saw the phrase earlier in the chat comments, like factory style or warehousing of residents. That home also contracted out its laundry services, and it also contracted out its food services. So at the first home I worked in, our laundry, housekeeping, and food were all provided in-house. In the second home that I worked at, the housekeeping was in-house, but the food services and laundry were not. We regularly had all sorts of issues with the laundry. One, in terms of running short of linens. Two, there would be lots of damage done to resident clothing, and residents' clothing would be dropped off in the wrong room and would go missing. And with food services, food is so crucial and essential to our daily life. The fact that food was being shipped up on a truck and rewarmed at the home and then put in front of residents to eat, to this day, I still cannot wrap my mind around it. I find it absolutely boggling in terms of quality of life and quality of care. So I had very disparate experiences at both of the homes, but the first case, shows that, we do have examples in Canada that we can draw upon to look at, as we move forward, what are good models of care that can be replicated elsewhere in existing homes, or as we move to build new homes across the country. So, organizations often say that long-term care in Canada is broken. I personally tend to avoid that discourse because, as I said, there's lots of examples of homes in Canada that provide amazing care, and the workers in the system are not broken. They are the foundation of the system, and we used to always call long-term care, when I worked in the system, a messy business. And that's not meant to be a pejorative. It is just reflective of the type of work that takes place in these homes. And those people, as I said, they're the foundation of the system and the base upon which we can build a better system. The workers know what we need to do to improve the system, and we should be drawing on their experience and expertise to learn more.
Great. Amanda, I was wondering if can you see Nancy's question in the chats there? It says, she says,
Yeah, it's about Riviera.
yeah.
It's about divesting Riviera and PSAC.
Mm-hmm. And I have a sort of a dream that the federal government would take it over, hand it to the municipal government to run, and support it, and just get them out of the business. In fact, there's been a lot of articles about the for-profits are likely to just get out of the business. But anyways, I don't want to divert too much from Nancy's point here about wondering if Amanda or anyone else on the call has any more intelligence about other unions, especially federal public sector unions, who are also wanting to get their pension plan out of for-profit nursing homes.
Mm-hmm. So I could say what I know, and then if he is willing, I might pick on Kevin Scarrett a little bit to see if he can provide any other intel for us. So everyone probably already knows that PSAC called for the federal pension plan to divest itself of Revera, and that came as a very pleasant surprise to many of us. The Canadian Labour Congress has put out a report and recommendations for reform in the long-term care sector. It does not contain a recommendation related to pension divestment around for-profit homes. And I'm not sure if there was some behind the scenes debate about whether or not it should be included. This issue is a bit thorny for labor unions because union members who sit as pension trustees have, I believe, a fiduciary obligation to essentially ensure maximization of profits for a pension fund, which can counter or trump ethical investment decisions. So it is definitely a thorny issue for unions. And if Kevin is still on the call, I'm just trying to see if he's still there. I know Kevin he's told me he's working on a piece that he's writing about this issue. So I'm not sure if Kevin, if you have anything else that you can add.
I think that one of the actions that we can all take is to take a darn good look at our pensions. We can take a darn good look at our investments, those of us who are fortunate enough to have them, and we can make some ethical decisions about how our money is invested. And we can advocate for divestment, and we can get ourselves out of the for-profit long-term care business. And I think a lot of times this is buried in a package of investments that you have to kind of go through and find it, but you can get that from your pension plan or from your investment provider. You might have an RRSP account that's invested in those. I really recommend that you take a look at it, and if you own shares, then get rid of them, and if you are part of a plan, make a fuss. I just think this is your moment, and that's an action you can take. And I feel really clear and capable of telling you that. The fact that fiduciary responsibility comes before death and ethical decisions is a problem of capitalism. That's something we live with, and it's something that we count on good citizens like yourselves to counter. Kevin?
Hi, can people hear me? Yeah. I'll just say quickly, I agree entirely with what Susan just said. And I'll just add that
I think Kevin is frozen.
Okay. Just for those of you who might not know, Kevin is the pension guru, as far as I'm concerned, in the entire country. And we are so lucky to have him here. He's just our go-to completely. And so I'm hoping that Kevin, we can't hear you, but perhaps even put in the chat if you can't, if the computer's going on you, it would be so great to hear from you, because we're just so fortunate to have your expertise.
Mm-hmm.
That's right.
Just, Mary Catherine, could I just butt in?
Sure.
Sorry, I lost connection. There was another question that had been earlier in the chat, and that was what has happened to some people who access home care, and when the pandemic hit, a lot of them weren't getting the visits that they needed. And personally, I'm concerned about how this government is looking at home care, and whether they see this as part of their strategy to say that they're doing something. Do either of you, Amanda or Susan, have any thoughts or any insight or reflections on the connection between home care and long-term care, and whether or not home care should be part of the seniors' health care under the Canada Health Act? Susan? I think
You want to go, Amanda?
Sure. So this is correct. I don't know what happened in Ontario with respect to the provision of home care during COVID, but I know definitely in Manitoba, for example, home care visits were cut, and somehow the government or relevant health authorities was determining which types of care were classified as essential and non-essential. And some folks were losing baths during the week, and I don't know how they could ever qualify that as non-essential. So this certainly was happening in some provinces. I don't know what the situation was in every single province, but we definitely have evidence that this has taken place in some provinces under COVID, which would certainly have a negative impact on quality of life and health outcomes for folks who are living independently at home, but who require assistance with care. For CUPE, our position is that we should also simultaneously have a fully public system of home care that exists in tandem with a public long-term care system. So we know that we can afford both systems. We don't think that the achievement of one public system should come at the expense of the other. We know very well that most folks would prefer to remain in home for as long as possible compared to moving into a long-term care home. Long-term care homes are sort of, an option for folks whose care needs are just so high that they cannot achieve or obtain relevant care in the home. We also know, as Susan pointed out earlier, that a small but growing proportion of residents in long-term care are people with disabilities, and those individuals, many of those individuals would much rather remain living independently in either assisted living or in their own homes, and they would only be able to do that through a full and robust system of home care.
So,
Folks, can I get in again?
Sure.
Say it's Kevin.
Sorry, it's Kevin again. Sorry, I cut myself off, I think, from my Wi-Fi. Just to finish one thought I was saying about PSP and Rivera. One of the unique things about that structure is that the ultimate owner of Rivera, this pension fund, is actually a federal crown corporation. And this point has been made, I think, in the House of Commons and other places. So I think the pressure that can be brought to bear on the federal government could really converge. And I think there's really potential to imagine that Rivera itself, which I think is the second largest owner of long-term care facilities, could actually be the beginning of a federal or a government-owned presence in the sector, and to which hopefully more could be added. So I just wanted to underline that point, that there's a real opportunity there if the pressure can be brought to bear on both provincial and federal governments and on that structure, that ownership structure of the federal public service pension plan.
Yeah, I think that's a great idea. I was wondering what people thought about the transferring for profits, especially I think it could be more possible with the federal government to transfer the ownership to the municipality.
That's right. This was a question that either Mary Catherine, you brought up earlier, or Catherine might have brought up earlier, that we forgot to come back to. And so this question is the answer, and Susan may have a better idea, for me, the answer to the question still remains a little bit unclear. You know, because so we're not sure yet who would put up the money to purchase homes. You know, the question of how much would be reasonable to pay for the homes, of course, is a question as well. And, you know, if the federal government provided the funding to purchase the homes, would the federal government then be the owner of the homes? Would they transfer ownership to the provinces, or since public homes are owned by municipalities, would ownership be transferred to municipalities? This is a crucial question that I don't personally have an answer to yet, and so I'm wondering if Susan has a better idea about that.
Yeah, I don't have a perfect answer to it, but I think it's pretty important to remember that municipalities, the way that they're funded, they're really creatures of the province. We act as if they're, you know, autonomous, but they aren't very autonomous at all. They're highly reliant on and have very little tax revenue creating activities relative to their budgets. So we really need to be looking at that when we start talking about municipalities taking on more responsibility for long-term care, and the ways that that can create, again, some of these systemic inequalities based on where they are located. So I think taking a look at that more closely would be really important and useful. You know, countries have done a lot of interesting things in order to raise capital at different points. And with the rocky stock market of the current period, I often wonder if it's, and very low interest rates, I'm wondering whether it's a time to return to savings bonds and whether Canadians would be willing to invest in raising public money for long-term care at this moment. Whether that would give Canadians something to, you know, put their money where their mouth was and make an investment in the sector. So I throw that out there, out to you as a bold idea to be thinking about in this particular moment, where we really do need to consider public funding and creating some capital in order to do some rebuilding and more building in the sector. So that's just my my bold idea. Getting back to home care, thanks Amanda for starting us off. It sounds like I have a million research projects, and and actually I kind of do. But we have another COVID-19 rapid response project on community care, and actually I think one of the people that works with me on that project, Christine Streeter, I think is on this is on this call. And what we are looking at actually is changing conditions. We did a study last year in June of the community sector, and we're repeating that same study with the organizations and outfits that we worked with in a year ago to see what has changed. And we're working with a whole lot of very active older adults and the organizations that support them and their families. And we're also working with all the workers that are working with them. So we're going to have some answers pretty quickly about what's happening in Ottawa with this sector, how things have gone and how things changed. We know what's happened at sort of the policy level, but we don't know how people's lives have been affected. And that's what I think is really important to hear and to bring into public discourse.
Excellent.
Yeah, for sure.
Excellent, Susan.
Nancy just made a good point there about a first step could be to close the tax haven loopholes so that there's more revenue for the federal government and provincial too, probably. But there's very, yeah, we had she mentions we found that the city Ottawa had no appetite for the adding additional homes, but they wanted to maintain the existing homes, which have had a better than average number of outbreaks and deaths, than lower than average of being a municipally run place. The other thing I like about the municipality is there's a democratic accountability to the community. Like none of the recommendations from the Fougere report, who investigated the violence, would have been automatically implemented in the for-profits or even in a lot of the not-for-profits.
Mhm.
So
I'm just going to mention here, if you've been watching, Grace Walsh is on our call, and she is very involved in the family councils and is suggesting that there are some municipalities, say, Grace, that are perhaps wanting to get out of long-term care. That's not good news.
mhm.
I've only heard that as a rumor. I mean,
Mhm.
every municipality has to have at least one home.
Yes.
And most municipalities are investing quite a bit more money to upgrade the staffing levels. And we've seen the results in terms of lower death rates in the municipal homes. So, I mean, I always, when people ask me, I always send them first to the municipal homes,
Yeah.
first, to go on the list for there. But I think it's a little bit worrisome. And I know we did write to all the counselors at one point and just said, when the pre-budget saying, please continue to invest in long-term care.
Mm-hmm. Thank you. Thank you.
And perhaps those have come up more recently, but that's been longstanding, actually, that municipalities have been trying to find their way out of long-term care for lots of reasons, including just their general budget pressures. And there was a huge fight in North Bay just a few years ago where North Bay was trying to divest a long-term care home to become a nonprofit. And, actually, I love to tell these tales. The fight was successful and the municipality retained the home. The community worked relentlessly, led by a chef at the home who mounted an amazing campaign, and the home to this day remains municipal. One of the challenges was that surrounding municipalities had been chucking in money for the long-term care home and for long-term care beds, but as their communities were dying, they didn't feel they could afford it anymore. So North Bay was left holding the entire or most of the budget bag and was feeling it was unaffordable. So these are the kinds of sort of geopolitical financial situations that are occurring. And Grace, I think your point that this might be happening more acutely because of fear of liability and risks around COVID makes complete sense to me.
Mm-hmm. Mm-hmm. I'm wondering, maybe, Mary Catherine, if we should begin to think about wrapping up, given the time. Mm-hmm. I'm wondering if either Susan or you, Amanda, have some final comments you wanted to make before we turn the meeting over to Nancy, who has some announcements about future activities. What do you think?
Good idea.
Amanda?
Sure. So, I mean, I'm very concerned. I used this phrase in a talk I gave for the NDP, jurisdictional hot potato, that I don't want long-term care to become, Premier Legault has said, just give us more money, return CHT funding to 50% of costs of healthcare, but feds don't do anything else. Premier Ford, other than requesting that the military be brought in to provide assistance, is also taking the position of, it's kind of hands off. And as Susan rightly pointed out earlier, other than BC, we don't really have any progressive governments across the country who I would say are going to come out swinging for support from the federal government for long-term care. So I keep trying to craft these responses instead of, pointing the finger at provinces and territories and making them the guilty culprits for the situation that we're facing in the sector. I try to reframe it as saying, we need improvements. You guys can't do this alone. We need to bring in the federal government to offer needed supports. And if we don't, we're going to continue to see the horrific situation that we're currently facing. Even if the current wave of COVID passes, it's going to come back. And if we don't make the systemic changes we need, too many people are going to continue to die. So I think we have to keep crafting those kinds of responses and finessing them so that, in part, the federal government doesn't try to weasel out of taking any responsibility, leadership, or action, and also so that our provincial premiers don't say, hands off to the federal government, let us just do what we want. We need them to collaborate and to work together on this.
Thank you, Amanda. Susan, any closing remarks?
Yes, I just want to say that, the Canadian healthcare system has been experienced assault after assault, and it has been Canadians who have fought back. It is because Canadians own their public healthcare system, take it very seriously, love it, continue to support it, that we continue to have it. And I think there's a big lesson for us in terms of long-term care. This is our system. It needs to be, we need to take responsibility for it. And the way that we take collective responsibility for it is to advocate with our governments and not let them off the hook.
Right. These
lives are not disposable. These people have died, and we have to make sure they haven't died in vain. This is our system. And I think that kind of language that's been so powerful with the Canadian healthcare system, in spite of constant attacks and erosions, I won't pretend, but I mean, it has been tremendously powerful, and we know this.
Mm-hmm.
I think we can do this. I think it's possible, and particularly in this moment with so many people galvanized, if people can think about this as their system. And to do that, we have to make it more inclusive, and I could do a whole nother session on that.
We may just do that
another day.
Mm-hmm.
Thank
And
you very much.
I do just want to quickly add, just to further draw on a point that Susan is alluding to, that for the sake of both the residents and the workers who have died because of the slow to lack of responses, not providing PPE, et cetera, all the issues we know that have contributed to the current situation, we absolutely must achieve reform in order to achieve justice for all those lives that have been needlessly lost.
Thank you. Thank you both, Amanda and Susan. That was really wonderful, and I'm so glad you were able to join us. And on behalf of everybody here, a big, big thank you. I'm going to turn the meeting over to Nancy, who has some announcements about further activities that we're going to be involved in. So just, Nancy, are you there?
Yes, thank you. Just a few notes. So we've certainly touched on a lot of things this evening, and I just want to take a few minutes of your time to let you know what we'll be doing in the coming months. One of the things that we get involved in is each year the Ontario Health Coalition organize a fall assembly with all of the provincial coalitions coming together to share our concerns. Collectively and democratically, we agree on a path forward, highlighting some of the priorities and campaigns in the coming year. And locally, our group, pre-COVID, hosts a monthly public meeting, often with invited guests such as Susan and Amanda and other healthcare specialists. And we organize locally around the Ontario Health Coalition provincial campaigns, but we also take the time as much as we can to focus on local issues right here in the Ottawa area and how we will be impacted by changes to the public healthcare system. In recent years, we usually organize a public forum in the spring and in the fall. Some of you may have attended our forums. We participate in an annual fundraising event, including the selling of organic garlic, which is donated by a number of Ontario farmers across the province. And that's going to be coming up again soon. We haven't yet received the go-ahead to return to our monthly public meetings, as you all know, but our local steering committee continues to meet weekly, and we also participate in weekly calls with the Ontario Health Coalition. In the coming months, as I mentioned, we're going to be selling some of the organic garlic, and we'll continue to closely monitor developments with COVID and with Bill 175 that's introducing major changes to home care. And as mentioned, there's been some discussion with the Public Service Alliance of Canada, calling out the Crown Corporation, who is actually the owner of Rivera, the for-profit long-term care homes. We're also, we're going to be continuing to monitor the Canadian Labour Congress. Someone had mentioned that they recently came out with a strong statement calling for private for-profit long-term care homes to be moved to public ownership. So things are changing daily and moving at a fast speed. An example is, you know, the Ford saying that he's considering giving immunity to the long-term care homes. That's something that we're going to be monitoring very closely. So we encourage you to we have a Facebook page. I'm not sure if everyone is familiar with it, but we encourage you to like the page and follow it. And if you haven't already done so, consider signing on to the Ontario Health Coalition mailing list to stay informed. And that will give you a heads up of when we'll be starting to sell the garlic. And also, we hope that we will host another if we're not able to do it in person in September, we'll host another Zoom call, because I think this went pretty well, and I certainly learned a lot, and I hope that you did as well. So I think I'll leave it at that.
Well, thanks very much, Nancy, and thanks again to Susan and Amanda. I'm sorry my voice keeps deserting me. Anyways, really appreciate, this is one of the largest meetings we've had, like especially Zoom, and we're trying to iron out the kinks, but I really thank people for their patience and for the comments. And once I figure out how, the meeting has been recorded, and we will send a link around to the folks who have attended, and maybe post it on the website. So thanks very much for attending. We were hoping to keep the meeting to like between an hour and a half, so we've gone a bit beyond that. So I just really want to thank the speakers. We've learned a lot, and certainly we've probably developed a fairly long list of major themes for more meetings around, you know, building up our public healthcare system. So thanks, everyone.
Thanks, everyone.
Thank you, everyone. It was a real pleasure. Thank you so much.
Yep.
Thanks, everybody. You've been really informative. Much appreciated.
Thanks.
Bye.
Bye.
It was excellent. Thank you. Great presentation.
Thank you.
Night, everyone.